Welcome everybody. Today I'm going to be talking about coronary calcium scoring for risk stratification and guidelines. By way of introduction, I am Matthew Budoff, Director of the Cardiac CT at Harvard UCLA Medical Center in Torrance, California, UCLA. When we think about coronary calcium, it's important to recognize that calcified plaque does not represent the total plaque burden directly. It measures just what we would call the tip of the atherosclerotic iceberg. This is a concept made popular by John Rumberger a number of years ago, that calcified plaque is about 20% of the total plaque burden, and this was derived from autopsies or ultrasound studies, and about 80% of the plaque is either soft or fibrotic. However, understanding that calcium is plaque, in other words, the larger the iceberg that we see floating above the surface, the more problems we know exist below, it's very helpful to have a total that the more calcium score, the greater the risk attack. So I often liken this to the iceberg that sunk the Titanic. When the Titanic was going across the Atlantic and it saw a big iceberg in its path, it didn't send divers below the surface of the water to see if there was any ice there that would rip the hull. It knew that it was in trouble. Similarly, when we see a lot of coronary calcium in an individual patient, we know that they have a lot of plaque, and some of that plaque is going to be vulnerable and some of that plaque is going to be soft, and therefore the more calcium we see, the more cardiovascular risk we know they have. Now there are really four primary uses of coronary calcium scores, at least that I think that we use most commonly and that are supported by guidelines. Most importantly, its use to screen patients with intermediate or low to intermediate risk. A positive scan indicates incremental risk and would alter the therapeutic targets. We would be more aggressive with LDL reduction and overall cholesterol management, blood pressure control, diet, exercise, smoking cessation, a lot of things that we can do for our patients' overall risk if we have information that they're at really higher risk than we otherwise thought. It can also help us tell us who doesn't need further cardiac evaluation. In other words, the warranty period for a calcium score of 0 is about 10 years. So if your patient has a score of 0, their risk of having a cardiovascular event in the next decade is really. It's been demonstrated to be a robust method to track progression of atherosclerosis. Last month, in just March of 2013, I published a paper that demonstrated that you're 4 times more likely to die or have a heart attack if your calcium score is going up by 15% per year. So important to recognize that an increase in calcium score is associated with increased cardiovascular risk. And make some prudence to probably repeat the score at a 2 to 5 year interval depending on the baseline score and the cardiovascular risk of the patient. Finally, improving compliance. We have excellent data, and I'll show you some today, showing you that the increased knowledge of knowing that patients have plaque lends itself to better therapies and to longer treatment. So here's one of the primary studies. There's a number of studies. I'm not going to have time to go through all of them, but this is the St. Francis Heart Study, 4,903 patients followed for almost 5 years, basically showing us these are event rates, no coronary calcium on the far left, no cardiovascular events virtually, and as the calcium score went up, as the plaque burden in the coronaries goes up, the cardiovascular risk goes up. Very simply, patients become high risk, 2% per year, 10-year risk of 20% with a score greater than 100. So a very easy number for us to remember. High risk is greater than 100, and of course, as the score goes up, the risk goes up continually. Here we can see the relative risks of those scores. You can see that for heart events on the far right, you are 10 times more likely to suffer a cardiovascular event with a calcium score greater than 100 as compared to those with lower scores. So 10 times more likely to have a heart attack or death, any coronary event, or really any cardiovascular event. I published a long-term follow-up in 25,000 patients. This was for all-cause mortality, but you can see a score of 0. Survival was well over 99%. So we have good long-term warranty information about a score of 0, and incrementally, as the score goes up, mortality goes down. It's a perfect association. So with every increment of calcium score, 10 and 12-year survival was worse. The 10-year event rates for a calcium score above 100, patients were 10 times more likely to suffer a cardiovascular event, exactly the same as those patients with that we saw from St. Francis. The definitive study was published in the New England Journal of Medicine in 2008. Score of 0, virtually no events. This is the MESA study, the multi-ethnic study of atherosclerosis, 6,814 patients. We now have up to 10-year follow-up, and the results are similar. This paper represented 3.5-year follow-up, but it was similar in Hispanics, African Americans, whites, and Asians. It was similar in men and women. It was similar in young and old. If your score is above 100, in this study, you are 10.26 times more likely to suffer a cardiovascular event. So exactly the same data reproduced in multiple cohort studies, that the higher the calcium score, the more likely you are to suffer a cardiovascular event. The American College of Cardiology and American Heart Association published guidelines for assessment of cardiovascular risk in asymptomatic adults. And in these guidelines, they gave calcium scoring a 2A indication. So measurement of calcium is reasonable for risk assessment in asymptomatic adults. They also gave it a 2A indication for asymptomatic adults with diabetes. They gave it a 2B indication, also indicated for persons at low to intermediate risk. And this is to help our younger patients and our female patients whose Framingham risk may not hit 10% at 10 years, but may also benefit from calcium scoring. This is a stronger combination of recommendations than any other screening modality that we know of. The Europeans in 2012 reiterated this in their guidelines. CT for coronary calcium should be considered for risk assessment in asymptomatic adults at moderate risk, 2A indication. But I think the most important piece of information comes from this slide. This is from Yaboa, from Wake Forest and JAMA, published in 2012. This was the MESA study, and now it looks at all different methods of risk stratification. So you can see on the left or the right, incident heart disease or cardiovascular disease, that the blue line represents the Framingham score. So that's the area under the curve. So what we want to see is a curve that's further to the left and up from that. And there's only one thing. He looked at 10 different ways of assessing risk, and there's only one curve that separates from the pack, and that's coronary calcium scanning. All the other markers, carotid IMT, brachial flow mediated dilation, family history, ankle brachial index, were not as robust. You can see on the darker line the family history and carotid IMT do separate and were statistically improvements over Framingham, but calcium scoring was really the most significant driving force in this study. That was reiterated in this paper by Annals coming out about the same time in 2012, also showing us different ways of screening for risk. But the curve that's far to the right, the hazard marker that's far to the right, that's the best predictor in this multivariate analysis, looking at all of these things combined, was the coronary calcium score. So the calcium score was by far and away the best predictor of risk. Again, carotid IMT also predicted risk independently. CRP also predicted risk in a borderline fashion. The confidence interval touched 1.0, but calcium scoring was much more robust than these other markers. So calcium scoring in multiple models is the best way to assess risk. And now I want to focus on its ability to reclassify patients. So yet another large population-based study. We talked about MESA and St. Francis and Rotterdam. This is called the Heinz-Nixdorf recall study, another large-scale prospective population-based study, this one done in Germany. And you can see here that if you had intermediate risk patients and you got a calcium score, 14% of them were considered high risk instead of intermediate risk. So we up-classified 1 out of 7 patients with a calcium score. They really had a lot of plaque and were high risk. More importantly, probably, is that we down-classified 63%. So we properly identified 63% of patients who we thought had some cardiovascular risk whose coronaries were normal. So very nice data to really strongly support an algorithm that a calcium score not only is the best predictor, but it's very robust and reclassifies over 75% of patients into a proper risk assessment of either high risk or low risk. The 2 randomized trials that demonstrated calcium scoring is beneficial. This is the first, the Eisner randomized clinical trial, 2,137 patients randomized to no scan. They got consultations and follow-up for 4 years, or a scan, which included consultation and the calcium scan. And we can see here that in the column marked CAC greater than 400, that those patients with higher CAC scores improved their cardiovascular risk across the board. They had a much lower LDL. They had a much better long-term change in their systolic blood pressure. They exercised more frequently. They used new lipid therapies, new blood pressure therapies, and new aspirin therapies much more frequently. They were more adherent to cholesterol therapy over time. So we matched intensity of risk with intensity of therapy. And most important, if we look at the cost of getting a scan versus those with a no scan, especially for those patients with a score of 0, there was actually cost savings. So we are not adding healthcare costs. If anything, we are benefiting the medical society by reducing costs by using a calcium score. Procedure costs went down by 37% over the next 4 years, and medication costs went down by 26%. So this is very important to understand that a calcium score we might spend more on those patients with a higher score, but we're gonna spend less on those with 0, and at least half the population has 0 in any given study. So we have a good opportunity here to save money for healthcare by adding calcium scoring to our algorithms. What do we do with a high calcium score? Can we treat it? Can we treat the cardiovascular risk? That was addressed in the St. Francis randomized trial. They were randomized with a high calcium score, greater than 80% compared to their age and gender, to either atorvastatin 20 or placebo. And treatment with atorvastatin reduced clinical endpoints by 30% and MI and death by 44%. So we take our high calcium score, we put them on a statin, and of note, in this study, everybody was on background aspirin therapy. But we put them on a statin and an aspirin, we reduced cardiovascular risk by 44% compared to aspirin alone. Event rates were more significantly reduced in patients with higher scores. The number needed to treat for a patient with a score above 400 to save a life or prevent an MI was 16. We treat 16 patients. 1 of them is still alive or doesn't have an MI. A huge potential cost savings here, and applying appropriate medical treatment to appropriate patients. So at least one treatment that we should strongly consider with an elevated calcium score is statin use based on this randomized placebo-controlled double-blind trial. Alan Taylor demonstrated compliance goes up. In pink are the patients who had a positive calcium score. This is 6-year follow-up of a healthy cohort. And patients were 7 times more likely, statin on the left, aspirin on the right, 7 times more likely to be on a statin and an aspirin at the end of the trial, 6 years later, if they had a positive score. So it improves compliance with therapies as well. We saw that in the Eisner trial. We see it again here in Alan Taylor's long-term work. So I'll leave you with this thought. This is from 5,000 years ago, that superior doctors prevent the disease. Mediocre doctors treat the disease before it becomes evident. That could be subclinical atherosclerosis as determined by coronary calcium or maybe carotid IMT. And inferior doctors treat the full-blown disease. And for too long, at least in cardiology, we've been waiting for the heart attack, waiting for the positive stress test, or waiting for the cardiovascular death to occur to jump in there with blazing. And I think it's now an opportunity for us to identify people before plaque becomes evident and get them on proper therapy. So I think, at least in the eyes of the ancient Chinese, we can move up from inferior doctors to mediocre doctors. Thank you very much, and I hope this was clinically helpful for you. Have a good day.